Alhamdulillahi Rabbil Alameen. Alhamdulillahi Rabbil Alameen. Now we are discussing the differential diagnosis of the chest pain. Now, chest pain do occur in the different settings. It can occur at any moment, in any scenario, in every settings, primary or secondary or tertiary care settings. Now, chest pain is the most horrible experience the person can have. That's why the chest pain is always related by most of the people to the heart diseases. They have not any concept that the chest pain can occur other than heart disease. This is the problem with the chest pain. So the chest pain should be evaluated properly in a stepwise fashion on a correct methodology. So we discuss the chest pain approach to the patient with the chest pain. Myself is Dr. Sayyid Ali Haidar. I am a visiting professor of medicine in Jinnah Sindh Medical University nowadays. Now this is the presentation which I have been given many times in different institutions. Now see and try to understand this presentation. Now chest pain is called a differential diagnosis. It's called somebody has got a pain in the chest. Take the proper history of this person. This pain duration is important. It is acute, subacute or chronic type of pain. Sudden onset, dramatic onset, where the part is involved, or which part is involved of the chest. Are there comorbids with the patients, or there is associated symptomatology associated with the chest pain? So the objectives are the overview of the chest pain, differential diagnosis, typical versus atypical chest pain, and evaluation of this pain, and review the patient cases. Now this pain occurs 6 million annual in United States and about more than 4 million in Pakistan. Chest pain is the second most common emergency department complaint. Patient with the chest pain present with a wide spectrum of the signs and symptoms. For example, sweatings and palpitations and other things, or breathlessness. It is up to the clinician actually to recognize this type of threatening causes of the chest pain from the non-life-threatening causes of the chest pain. The epidemiology, which is the research work has been done. In most of the cases, it was found that the musculoskeletal conditions are responsible for the chest pain. And in emergency department, GI disease is about 19%, and serious cardiovascular disease 16%, and psychologically 8%, pulmonary disease 5%, and non-specific chest pain, which is not related with the chest at all, and is non-specific, is 16%. It means that the ischemic heart diseases are not the commonest cause of the chest pain. This is a clinical pearl that chest pain is not equal to the acute coronary syndrome. Not every chest pain is the acute coronary syndrome. But positive troponin if occurs, again it is not equivalent to the acute coronary syndrome because it may be false positive enzyme may be positive. The patient should be taken as a whole. Now there is life-threatening causes of chest pain. And they are the acute coronary syndrome. I said that is 3 types: unstable angina and ST elevation myocardial infarction and non-ST elevation myocardial infarction, aortic dissections, pulmonary embolism, pneumothorax, tension pneumothorax, pericardial tamponade, and mediastinitis, for example, esophageal rupture. These are the life-threatening causes of the chest pain. You have to do very, very emergent management. Differential diagnosis is manifold. As far as non-ischemic cardiovascular is concerned, aortic dissection and myocarditis, pericarditis. These are non-ischemic. They are cardiovascular causes, but they are non-ischemic. Chest wall, cervical disc disease, cervical spondylosis can cause severe pain in the upper part of the chest. Costochondritis is again an important disease. It is also known as the Bonham disease, fibrositis, and herpes zoster, preherpetic neuralgia, that is neuropathetic pain, rib fracture, and the sternoclavicular arthritis, and the other causes are also there related with, for example, the pain rising from the breast, that is mastitis, can cause the chest wall pain. Even other than that, the pulmonary causes like pleuritis, pneumonia, pulmonary embolism, tension pneumothorax. Psychiatric causes are there, affective disorders like depression, anxiety disorders, hyperventilation, panic disorder, primary anxiety disorders, and the somatic form type of disorders like thought disorders, fixed delusions. There are a lot of causes of chest pain. It means that there are a lot of causes. Some are ischemic, which I have said there are 3 types of ischemic type of a pain, and otherwise they are divided into non-ischemic, cardiovascular, chest wall, pulmonary, and psychiatric. Another you can add from gastrointestinal, the biliary tract, rising from the biliary tract, cholangitis, cholecystitis, choledocholithiasis, colic, abdominal colic, esophagitis, spasm, GERD, that is reflexive rupture of the esophagus, pancreatitis, peptic ulcer disease, non-perforating or perforating type of it. These are all referred pain from the abdomen to the chest. Another syndrome which is a very, very unique syndrome, and I have seen 2 or 3 cases. This is called the precordial catch syndrome, also known as Texidor tinge. It is a common cause of the chest pain in the children and adolescents. It is a very unique type of a problem. Now it occurs through less frequently in adults. It manifests itself with a very intense, sharp, stabbing pain, typically at the left side of the chest, generally in the cartilage between the bones of the sternum and the rib cage, which is worse when taking the breaths. If you inspire, there will be pain. You expire, you relieve the pain. Often the symptoms are described as bubbling in the chest. Sometimes associated with feeling of a popping, bubbling and popping, or cracking sensations, which usually resolve the pain. Patients often think that they are having a heart attack, which causes them to panic. I already said that I have diagnosed 3 or 4 cases of this precordial catch syndrome in my practice. And they're all young people about 19 to 25 years of age. Now, typical versus atypical chest pain. Characterize typical or atypical. Now, typical characterized as a discomfort, pressure rather than pain. Time duration is more than 2 minutes. Provoked by the activity, exercise. It is a radiation to the arms or the jaws or the tongue. It does not change with the respiration or position. Associated with the diaphoresis, nausea, and relieved by the rest. It can be relieved by the nitroglycerin. Atypical chest pain can be localized with one finger. You can point one finger to the chest. If it is a pointing of pain, if somebody is pointing the pain in the chest, it is least likely to be ischemic. It is a constant pain lasting for the days, and the fleeting pains lasting for a few seconds. It is a fleeting type of pains. It is ascending, escalating type. Pain reproduced by the movement and the palpation. If you will touch that area, it will be tender. It is overall review which is given is typical versus atypical chest pain. In the description of the pain as related with the myocardial infarction or in ACS, there is relation to the right arm or the shoulder, relation to the both arms or the shoulders, exaginal, or relation to the left arm or associated with the diaphoresis. It may be associated with the nausea or vomiting, worse than previous angina or similar to previous myocardial infarction, and describes as pressure. And these are the descriptions which are seen with the acute coronary syndromes. Description which are least likely causing the myocardial infarction are pleuritic type of a pain or a positional pain. It may be sharp pain. You can point the area of the pain. Pointing is called pointing phenomena. Reproducible with the palpation. Tenderness is there. Inflammatory location, and it is non-exertional. Least likely to be ischemic pain. It means that. So overall, I've said that the typical versus atypical chest pain is a myocardial infarction. Is the chest pain radiates to the both arms with hypertension. There will be third heart sound, diaphoresis, pleuritic chest pain, and palpation to the tender area, reproduce the pain. Now, this is in most of the studies they are present. But in pneumonia, which also causes the pain, it is the typically chest findings of the pneumonia. In the heart failure, there are typically exertional dyspnea rather than pain. In a panic disorder, it is nervousness regarding with the pain. The patient wants to run away from the site. And chest wall pain, that is palpation on the tender area, will reproduce the chest pain. A movement will definitely increase that pain. This is the accuracy of the chest pain diagnosis. Using the history, you take the history properly. History taking is an art, especially regarding the chest pain is concerned. Now, evaluation of the chest pain, the scenario is given. It is 2 a.m. and you are the house officer, or you are doing the internship there. The nurse pages you and tells you that Mr. S, a 67-year-old male with a known history of the coronary artery disease, who is admitted for the acute renal failure, is having chest pain after he walked back from the bathroom. what would you do next? Now ask the nurse for the most current set of the vital signs, and ask nurse to get an electrocardiogram, and ask the nurse to have the admission EKG at bedside if available, and go to see the patient. Electrocardiogram at the bedside is available. If it is, if it is possibly it may be sent by the WhatsApp or other means to the doctor. You can see the ECG at your room, but it's better to go to see that patient. When at the bedside, determine if the patient is stable or unstable. Read and interpret the electrocardiogram. You have to be expert in reading the electrocardiogram. Compare the electrocardiogram to the old electrocardiogram if it is possible or if it is available. If the patient looks unstable or has concerning ECG findings, call your senior resident for the help. If the patient is stable, perform a focus history. Does the patient have the coronary artery disease or other cardiac risk factors? Is the pain typical or it is atypical? Is the pain similar to the prior MI? And perform a focused physical examination. Look for the tachycardia, hypertension, hypoxia, or vital signs. Generally sick appearing, actively having chest pain. And go for the head and neck and eye examination, and jugular venous distension, carotid bruit. Chest, you have to examine for the rales, the wheezes, and other added sounds. Cardiovascular system, new murmurs, reproducible chest pain, and third heart sound, that is called S3 gallop, if it is present. Abdominal tenderness, pulsatile mass was there or not, and the extremities, edema, peripheral pulses, skin rash on the chest wall. You will see labs are concerning chest X-ray is important. The cardio biomarkers, specifically enzymes, the arterial blood gases, and telemetry can be done. Telemetry is the technique in which you send the reports to your seniors. And ICU, of course, admission. If your senior said that it is definitely a life-threatening type of a chest pain, you have to admit this case in ICU. So write a clinical event note. Always record what happened, what you have done to this patient. This should be, you make your habit, because it is a legal problem afterwards. Now, scenario 2 is that you are the orphan intern, means you are alone, and you get a page from 67121 and the DACR, the doctor at the duty, informed that you have a 45-year-old female in the emergency department who is being admitted to the Hallstein service for the suspected case of the ACS. How would you approach this patient? They are suspecting that this patient has got the acute coronary syndrome. To get report from the emergency department physician about the patient, ask the emergency physician about the patient's initial presentation, get last set of the vital signs, and ask the emergency physician to order the electrocardiogram and chest X-ray. Now go to the UH portal and print out an old EKG for comparison. If it was there, the old record is there, you can compare. Review prior discharge summaries if it is possible that the record is available. Quickly review the prior cardiac workup, echo or stress test and the cath reports if they were available. Review any labs, imaging, or from the current ED visit, you do the X-ray chest, labs, means enzymes. So review these findings. Now these are the two cases which I have just presented in front of you, and see the patient commonly. This type of call occur when you were sitting in the room, and the emergency doctors, they always call the physicians to come and see the patient or do evaluation of this patient, specifically speaking about the chest pain. Case number one is that you are on the Western team and the nurse calls you and tells you that Mr. Z suddenly started having chest pain and her oxygen saturation went from 94 to 98% on the 2 liter via nasal cannula. Now this is the electrocardiogram, and she has, you see that she has got already the history of COPD exhibition. She was admitted for the COPD exhibition, that is the chronic obstructive pulmonary disease. She had prior history. Now, this is the EKG and admission is concerned. See the leads, chest leads, very, very cautiously. 1 AVL, you see any ST elevation or depression. Then you see 2, 3 and AVF for the same. If there is any ST elevation and depression, 2, 3 and AVF. It is inferior wall. So V1, V2, V3, V4, V5 and V6. The same thing. ST elevation or ST depression or any Q wave formation, because the ECG is learned like that. There are many things to be learned from the electrocardiogram. Although this patient has the COPD, but the P wave morphology is not indicative of the pulmonary hypertension in this case. So these and this is the case. Just see. You have to describe the thing. Here you in this ECG, which I just shown you, that the clinical examination, the patient tells that she was feeling better, getting the nebulization during her admission, but suddenly developed the chest pain that is left-sided, and it is pain is 8/10 and worse with the breathing. She was never experienced pain like this in the past. Very, very severe pain. And vital sign, the afebrile heart rate is 120, BP 110/70. The respiratory rate is 28, which is higher. Oxygen saturation drops to 89%. And the 2 liter. Physical examination was the general. In distress, using excessive muscle of respiration. Lungs, it is no rails, wheezes, it is normal. Otherwise, it is the breath sounds are not very, very, audible. Heart is tachycardia, and there is S1, which is loud, S2, loud S2, but normal S1, no murmurs, and the abdominal sound is soft, and it is non-tender and active. It is working condition. Extremities are warm and well perfused. The labs have been done, the CBC with normal limit, and the respiratory function was done with a normal limit. The natriuretic peptide was 520. D dimer was positive, which is important. ELISA D-dimer positive means something is broken down from some coagulum. Troponin is 0.12, which is normal. Now here is what this is the same, I would say. Only thing is this, there is slightly, you see, in 2, 3 and AVFs, slight, ST elevation is there. It is early depolarization. I will not say that this is actual ST elevation. As far as 1 and AVL is concerned, they are normal. There is nothing seen here. In cases of V1 and going for the AVR and AVL and AVF, and V1 from V2 to V3, V4, V5, V6, specific signs are not present here in this condition. Only the part which we see here is the tachycardia, which I noticed. Otherwise, only in the third lead there is a T wave inversion. Otherwise, there is not very specific. This is X-ray. In this X-ray, you see the most of the bronchovascular markings are not seen in the periphery. They are only seen in the around the hyla, but not on the periphery. There are very, very few. Now here you see in this case, in the lungs again the same thing. There is a very dark, the lungs window. Aorta is normal, the superior vena cava and other structures are seen normal, but the vessels are not visible, and that is the unique thing. Now this is the case of the pulmonary embolism. She developed pulmonary embolism because she was bedridden and she has got COPD, the risk factor. So the Bell model for the clinical diagnosis of pulmonary embolism was there. Point scoring, it is the clinical sign and symptom of the DVT. Measured leg swelling or the pain with the palpation deep. 3 points. Pulmonary embolism is likely to be more likely than the alternative diagnosis, 3 points. Heart rate is more than 100, 1.5 points. Immobilization was there. Bed rest except for the bathroom access, etc. 1.5 points. Previously objectively diagnosed DVT or the pulmonary embolism, 1.5. Hemoptysis 1, and malignancies associated malignancies was there, 1. If it is less than 2 points scoring, the risk of the pulmonary embolism low. Is 2 to 6 points is moderate. More than 6 points is high. So in this case, the points, the score here, it is about 4. So it is a risk for the pulmonary embolism in her case is moderate. To me, it is moderate. To diagnostically, the testing is pulmonary angiography. It is the gold standard. CT angio. Spiral CT can be done, and the oxygenation ratio, the inhaled oxygen with the alveolar oxygen, that is V by Q scan, that is called. How much oxygen is taken inside and how much it can absorb. And this type of a scan is called V by Q scan. So it is helpful in detecting the chronic type of the thromboembolism, venous thromboembolism. D-dimer is less than 500 nanogram, helps to exclude the pulmonary embolism in patients with a low, moderate pretest probability. Now treatment in this case, the anticoagulant will be given, heparin or low molecular weight heparin. For unstable patients, catheter embolectomy or surgical embolectomy can be done. The patient has a risk for the bleeding. The IVC, this is called the inferior venous cable filter, is an alternative. Case 2 is a 24-year-old male is being admitted to you from the emergency department for the chest pain and the electrocardiogram abnormalities. Here the history, which is past medical history, was taken SLE. He had the history of SLE or asthma. You go to see the patient and tell that he has had this chest pain for the last 2 days. It has progressively gotten worse. His chest pain is worse with breathing. He does report getting over a recent urinary tract infection few days ago. The vitals, temperature 38.1, heart rate 104 is higher, BP 140 by 76, respiratory rate is 20, and there is oxygen saturation 95% is on 2 liters per minute. And physical examination generally in mild distress due to the chest pain, leaning forward while in bed. Lungs, it is the normal features which are seen. It is the vesicular blood sound which are present. Chest wall, no visible rash, chest wall, non-tender to palpable, and heart was tachycardic. S1, S2 is audible, no rub. The rest of the physical examination was unremarkable. Labs was done, the WBC for 14,000, which is more than that. And the acute myocardial infarction panel negative. With the other, the routine follow-up tests were normal. Chest X-ray was negative. This is the case which is seen here. You see, in 1, in the 2, even AVF and AVL, even B1, B2 and other leads showing the ST elevation, and it is the ST elevation which is very, very unique type of ST elevation. It is going up with the T wave above the baseline. And this is a very unique type of ST elevation. It is a global, overall, you can see. So it is the refers to the inflammation of the pericardial sac. It is the pericarditis actually, preceded by the viral syndrome, the flu-like syndrome. Typically, Picrono group of viruses are there. Coxsackie viruses can cause it. Typically, patient with a sharp pleuritic chest pain, it is relieved by the sitting or by leaning forward. Pericarditis, there are a lot of causes of pericarditis. It is a big chapter. It may be it may be infected causes, non-infected causes may be there. Malignancies, radiation, and autoimmune disorders. For example, in this case, SLE was there, already there. Trauma to the chest wall and drugs, the hydralazine and the procainamide, etc. There are a lot of causes of the pericarditis. And there are many types of pericarditis we will discuss later on. It may be acute pericarditis or acute myocardial infarction, or it may be early repolarization. There are 3 differential diagnoses made here. Here, acute pericarditis, ST elevation in the many leads, it is global, I said already. There is no ST depression. In AMI, ST elevation is anatomically contagious leads, 1 AVL or 2 or 3 contagious leads. With the possible reciprocal ST depression, you will see. In early repolarization, the ST elevation in the middle and the left precordially, but may be widespread. Early repolarization, it is the what is called as the pseudo infarction. It is called pseudo infarction pattern ECG, early repolarization. Now, here in acute pericarditis, the upward concave ST segment elevation is concavity upwards. In acute myocardial infarction, usually it is convex. In early reposition, upward convex ST elevation. And in case of the acute pericarditis, no T wave inversion leads with ST segment elevations. But in acute myocardial infarction, T wave inversion leads with the ST segment elevation as myocardial infarction involves. In early repositions, many may have T wave inversion leads with ST segment elevation, it's possible. PR segment depression and Q waves during evolution can be seen in acute pericarditis. No PR segment depression are there, and many have Q waves during evolution. When it resolves, acute myocardial infarction. No, in cases of early reposition, there is no PR segment depression and no Q waves. So diagnostic criteria, at least 2 criteria from the 4 should be present in diagnosing acute pericarditis. Typical chest pain, pericardial frictional rub, suggestive ECG changes. I have already said is ST elevation, which is concavity upwards, and the T wave is off the baseline, and new or worsening pericardial effusion associated. If it is this is the diagnosis of pericarditis, and it is the cause of the chest pain. You diagnose very correctly. Now, case 3 is that you are evaluating a patient on the Carpenter team with chest pain. Carpenter pain. Now, a patient is a 67-year-old male with the family history of hypertension, and he's got the lung disease, diabetes mellitus, and coronary artery disease, and he has the past history of the percutaneous coronary intervention. The coronary angioplasty has been done to the left descending artery in 2007, who is admitted for the left leg cellulitis. He develops new onset chest pain that is retrosternal 7/10. It is, this is the scoring. It means severe pain associated with the nausea and diaphoresis. It says that the pain is related to his left jaw and very similar to chest pain he had during his last myocardial infarction. Vital signs: the temperature 37, heart rate is 108. The higher one is tachycardia, blood pressure 105. By 60 it is lower down. Respiratory rate is 20, normal. Oxygen saturation is 93% on the 2 liters. On oxygenation on the room, on the room temperature, and in the emergency room, its saturation is 93%. Now, physical examination is generally actively having the chest pain and diaphragmatic lungs rails at the bilateral basis, heart tachycardia. It is the S1 is normal and S2 is normal, no murmurs or rubs. Rest of the examination is benign. Labs, CBC with a normal limit. The other the routine examinations was done normal. Troponin is 3.2, CKMB is 9, and the creatinine kinase is 345. So it is higher, the enzymes are higher in this case. You see in this electrocardiogram, there is from 1 and AVL there is ST depression, very clearly seen. In the 2, 3 and AVF there is ST depression in 2 and in AVF. But in V1, if you see V1 and V2 and V3, they all shows the ST elevation. It means this is a case you see, because enzymes are positive, there is typical There is a chest pain. I already said it is central chest pain. It already has got the history of the same thing. Probably he may be suffering from the reinfarction, and it is the anterior wall infarction, and there is reciprocal changes seen in the electrocardiogram. The risk stratification is called TIMI, TIMI risk stratification for unstable angina or non-ST elevation angina for both. Historically, the age 65 years, 1 point. If there are 3 CAD risk factors, like for example hypertension, diabetes, etc., 1 point. Known coronary artery disease, stenosis more than 50%, 1 point. And the acetyl salicylic use in the past 7 days, 1 day, 1 point. Presentation is recent, less than 24 hours, severe angina, 1. And increased cardiac markers, 1. And ST elevation more than 0.5 millimeter, 1. The risk score stratification is here 0 to 7. And the risk of the cardiac events by 14 days in TIMI classification, it is risk score, if it is score is 0 to 1, the death or MRI chances are 3 only. Otherwise the death, MI or the urgent revascularization chances are 5. On the other hand, if the score is 6, the death or the MRI chances are 19, and the death or MRI or urgent revascularization is 41. And this is the research work which is done as a risk stratification of any case of UC of the acute coronary syndrome. Here specifically they are speaking of unstable angina or non-ST elevation myocardial infarction. Now here this diagnosis they have done is the non-ST elevation myocardial infarction. It is the management of the unstable angina of the non-ST EMI. This is the emergency. On emergency you give the aspirin, and you can give the heart rate control with beta blocker. Metoprolol is a good drug. Statins should be given, and nitroglycerin sublingually should be given after every 3 to 5 minutes. And you give the clopidogrel, ticlopidine, etc., which will also be given. Anticoagulation should be done to this patient. Oxygenation and morphine should be given to these patients. The clinical pearl is the use the chest pain order set. Now this is the order set which is given here. How you will evaluate this one? This is the chart which is made for the hospital purposes, and this is the order set. You give the order for the drugs, how much drugs are given. It is the order set. The quick cases are revealed here. The case 4 in front of you, you should see the axis chest. You see in this axis chest there is monitor, cardiac monitor is also being put, and there are a lot of tubes are placed in this chest. He has got 2 important homogeneous geometrical type of opacities on the left and on the right side. And this is what is probably he has pacemakers in his heart. You find out the patient is having crushing chest pain relating to the back. His blood pressure in the right arm is 193 and the left arm is 160/99. what is on the top of your diagnosis. Again, see this case. Now, see the upper part of the mediastinum is very wide, and there is monitoring leads which are placed on this chest wall, which I said previously that this is probably they put the pacemakers. No, they are not pacemakers. These are the leads, chest leads which are placed, monitoring leads. The upper part of the mediastinum is very wide here, and the upper part of the aorta is touching the second or the first rib, and we find that the patient is having the crushing pain relating to the back. On the right arm, it is 193 by 112 blood pressure. On the left arm, 160/99. This is discrepancy between the right arm and the left arm. If this occurs with this type of the X-ray and this type of ECG, then according to the diagnostic criteria, it is aortic dissection. Stanford classification: type A involving the ascending aorta, type B involving the other part of the aorta other than ascending. Diagnostic imaging is the X-ray chest, which has a widening of the chest. Said CT chest with contrast is a very good option. MRI chest and the transthoracic echocardiography can be done, and endoscopic echocardiography is more useful rather than you go for the transthoracic echocardiography. Management of the aortic dissection: type A, if it is ascending aorta, surgical always, be it medical. Medical therapy, remember that the heart rate and the BP control should be done. The goal is that the heart rate should be less than 60 beats per minute, and the systolic blood pressure is 100 to 120. Use IV beta blockers, labetalol, esmolol. Can also use etoposide for the blood pressure control. Do not use the directly drugs which are acting on the cell wall, on the vessel wall. For example, hydrolazine. For example, calcium channel blockers. You do not use in aortic dissection. 5. This is the case number 5. This is a 45-year-old male with the medical history of rheumatoid arthritis who presented with the progressive shortness of the breath. He was found to have right-sided pleural effusion and underwent the guided thoracosynthesis, ultrasound guided thoracosynthesis with the removal of 1.5 liters of pleural fluid. 2 hours after this procedure, he developed a new onset right-sided chest pain. It was left-sided and the right-sided pleural effusion was drained out. But after 2 hours, again there is a right-sided chest pain. And this is the X-ray which was done after that procedure. You see that the X-ray is clear. The bronchovascular markings are visible in this X-ray. So, only thing is this, that the peripheral, in this X-ray, the bronchovascular markings, they are absent in the right side of the upper part and the middle part. Most of it, there is no left, no bronchovascular markings. Then only aerograms are there. So this is the diagnosis of pneumothorax. You have done the procedure and a pneumothorax occurs. You give supplemental oxygen and observation in stable patients. And needle aspiration should be done to save this patient if it is possible. And chest tube replacement should be done. And if it is, it should be placed for 1 or 2 or 3 days. Chest tube placement should be done also in unstable patients. Summary is that the chest pain is a very common complaint It's very common. I already said I've seen many cases and different scenarios, but has a broad differential. Always try to rule out the life-threatening causes of the chest pain. It is important to remember that the troponin elevation does not always mean ACS, because there is a false positive troponin. Use the history, physical examination labs, EKG, and imaging to commit your diagnosis. The constellation of the factors are important to diagnose the cause of the chest pain. Whenever you are stuck, you ask for the help. Your seniors, your specialists are there to help. Thank you for listening this presentation which I have given. It is the differential diagnosis of the chest pain only. I have not discussed the acute coronary syndrome in detail. Inshallah, on the next occasion, I will try to discuss the acute coronary syndrome, how you will diagnose and how will you manage. Thank you very much.